Thank you all so much for having me and taking the time to join us. Just by way of background, I'm a family physician by training. I see patients on a mobile health center in Miami Gardens, just north of Miami. Most of my patients are uninsured. They're very marginalized, underserved. And I am lucky enough to practice in an integrated care model where I have both a licensed clinical therapist and a psychiatrist who is available to me for consult at all times, given that I see high mental health acuity patients and don't have a lot of referral services available to me, given that they are primarily uninsured. So I'm really happy to be able to talk to you a little bit from those experiences and also from my experiences in primary care today. So I have no conflict of interest to inform you all of. By the end of the session today, I hope that you will be able to report on screening, evaluation, and management guidelines for 5 of the major cardiovascular disease risk factors, those being obesity, smoking, hypertension, hyperlipidemia, and diabetes, and then also to articulate some of the considerations that we have specifically for people with serious mental illness. That being said, there are a lot of other risk factors for cardiovascular disease, such as a family history of heart disease, physical inactivity and unhealthy diet, and a history of preeclampsia during pregnancy. And given that this is, a 40-minute talk, I'm not going to be able to talk about all of those today. And even getting these 5 risk factors into a 1-hour presentation is a bit of a feat, as I'm sure you all realize. So just to start with a basic definition here, what is cardiovascular disease? This encompasses various atherosclerotic conditions that affect the heart and the blood vessels. And so that includes coronary arterial disease and cerebrovascular disease, or what we call MI or heart attack, and stroke. This is the leading cause of both morbidity and mortality in the United States, and accounting for about 1/3 of all deaths among adults. So that means that it's something that as a primary care doctor, I talk about every day with every patient, even if they're healthy, even if they don't have any of those risk factors present right now. My goal is to keep it that way for my patients and the communities where I work. And importantly for you and perhaps the patient population that you're dealing with more, cardiovascular disease is thought to account for about half of excess mortality for people with schizophrenia and serious mental illness. So why or what do we specifically need to consider when we're talking about this population of people with SMI and cardiovascular disease? So disparities in healthcare access, utilization, and physician adherence to screening guidelines mean that this patient population experiences excess mortality from these diseases. And so it may be that the physicians don't adhere to screening guidelines as closely because they are focused more on mental health concerns, which may seem more acute or may seem like insurmountable kind of barriers to get to addressing other issues such as obesity or smoking or diabetes or impaired fasting glucose. And so the integrated approach to care, where you have a team with a primary care doctor and a psychiatrist or other mental health outreach workers working together and actually communicating and talking, really helps to bridge this gap. Furthermore, kind of outside of the social determinant of health framework, you also have side effects of psychotropic medications, including weight gain, and this high prevalence of smoking and poor diet that exists within this community. And all of those things kind of come together to create challenges with treatment plan adherence. So if you're giving lots of other medications, maybe not focusing on that counseling about metformin, about diet, about nicotine replacement therapy, patients are going to have a hard time adhering with that on top of everything else, all the other challenges and all the other treatments that they are facing and following. So to start first, to talk about dyslipidemia, this has an extremely high prevalence in patients with schizophrenia, up to 70% in some studies, and a greatly increased relative risk compared to the general population. The numbers are slightly lower for bipolar disorder, but still most certainly a disproportionate burden of disease. And so I want to talk a little bit about the ACSVD risk calculator that came out in 2013 from the American College of Cardiology. This is a risk calculator that now has kind of infiltrated how we're thinking about therapy for hyperlipidemia and also therapy for hypertension most recently. And it really has meant that we're getting away from target levels. So when you were in medical school, you were probably talking about goals of LDL of 70 or 100 or 130, depending on somebody's risk factors. But now we're using this more this risk model to estimate somebody's atherosclerotic disease risk in the near future and over their lifetime, and using that percent calculated risk to determine what treatment is appropriate for them. And so, as I'm sure that you are aware of, just from the mass media, even there's been a lot of controversies regarding this 2013 risk calculator that came out. It was shown to really overestimate actual risk in multiple external validation cohorts. And there were lots of jokes about, oh, we should just put statins in the water, particularly if you're an old man. And so there's been a lot of controversy surrounding this and the fact that it really recommends that most people, particularly older people, end up on a statin medication. However, that being said, it's important to also understand that this may underestimate cardiovascular disease risk for people with serious mental illness, given that they have a higher baseline risk and that mental health is not calculated into this calculator. To kind of use this along with your clinical judgment and your knowledge of your patients. If you Google ASCVD risk calculator 2013, you'll come up with a screen that looks like this PowerPoint screen here. And you can easily plug in the numbers for your patients. And again, for our population of people with serious mental illness, the risk calculator likely underestimates risk. They're at an increased risk for cardiovascular disease, even when controlling for other factors. And they also have an increased risk at an earlier age. And one of the great kind of criticisms of this calculator is that risk is a predominating risk, or age is a predominating risk factor here. So I use, because I'm a primary care physician, I use the USPSTF guidelines frequently to guide my treatment decisions and my screening decisions for my patients. And so I'm going to present for each of these risk factors, the USPSTF guideline, along with other society-specific guidelines and the ADA recommendations, the American Diabetes Association. And so the USPSTF takes a slightly less aggressive approach to statin therapy. And so they feel that statins, or their review of the evidence, showed that statin use may be beneficial for the primary prevention of cardiovascular disease events in adults with a 10-year event risk of less than 10%. They felt like there was a much smaller benefit because of a lower probability of disease. And so they really started to look at people who had a risk above 10% as people who would benefit from a statin medication. So really from the USPSTF guideline, we end up putting fewer people on a statin than we do from the American Heart Association guidelines from 2013. So along with the risk calculator guidelines, there's also treatment guidelines that come out of that risk calculator specifically for dyslipidemia. This is a hard slide to read, but if you have all of this information for your patient, it's actually a very easy algorithm to follow. And so on the next slides, I have just zoomed in a little bit more the guidelines here. And these are the 3 categories of patients who would end up on a statin almost regardless of their other risk factors. So anyone with clinical atherosclerotic disease who is less than 75 is recommended for a high intensity statin. If they're over 75 or not a candidate for a high intensity statin, maybe due to side effects, then they would be recommended for a moderate intensity statin. Any patient with an LDL over 190 is recommended for a high intensity statin, or anybody who's diabetic with an LDL greater than 70 is recommended at least for a moderate intensity statin, and perhaps for a high intensity statin if their risk of ASCVD is greater than 7.5%. And so you can see there that we're not really talking about target levels, and we really then just recheck lipid levels to check for adherence, and also to see if if the medication is not having a strong effect, then we would talk about increasing the intensity of the statin for that patient. This is the bottom part of that algorithm that I showed a few slides ago. And this is looking more at using statins for primary prevention and which patient populations would benefit from that. So you're looking at anybody with an ASCVD risk greater than 7.5%, ending up on a higher intensity statin, and greater than 5, but less than 7.5, ending up on a moderate intensity statin. And then definitely as part of all of this is talking about increasing physical activity and also eating a well-balanced kind of low-fat diet, which I'll briefly mention shortly. So the ADA has screening guidelines as well. These are specific to people with diabetes. They recommend that in adults not taking statins or other lipid lowering therapy, that you should obtain a lipid profile along at the time of diabetic diagnosis at that initial medical evaluation, and every 5 years thereafter if they're under the age of 40, or more frequently if indicated. And then if you're going to start a statin medication, you should obviously obtain a lipid profile at that time, and then 4 to 12 weeks after initiation or a change in the dose, and then annually thereafter to help monitor the response to therapy, and then also to inform adherence. And so some of those recommendations would apply to anybody regardless of whether they have diabetes. And then, in practice, we definitely monitor lipids much more frequently than every 5 years, even if they are normal, particularly in somebody with diabetes who may be at risk for more of a metabolic syndrome type of picture. For people who are not diabetic, the American Heart Association recommends doing their ACSVD risk calculation every 4 to 6 years. So again, that's not very frequently, and in practice, we end up checking lipids every year, and particularly in patients who have other risk factors for dyslipidemia, such as obesity. So in terms of treatment here, there's a multi-pronged approach. You can see on the right side of my slide, I have a lot of different statin medications listed, from low intensity statins to high intensity statins. And your risk calculator helps guide you in which medication to choose. Cost may also be a factor when making recommendations to patients. And then you also want to, obviously, just like with any of these risk factors that I'm talking about, you want to talk to patients about their diet and exercise. And so a heart-healthy diet here means minimizing trans and saturated fat, talking about omega-3 fatty acids and vegetable oils, eating whole grains, fruits, and vegetables. When I gave this presentation up at USF last month, there were some questions kind of about how do you balance a low cholesterol diet and a low low carbohydrate diet for patients with coexisting comorbidities. And that's definitely a very complicated question because patients end up feeling like they don't have anything kind of left to eat. And so I like this more general heart healthy diet approach where you're talking about the whole grains, the fruits, the veggies, and then you're not telling people not to eat any fat, not to eat any oil. You're really just more emphasizing this well-rounded diet rather than just cutting things out completely. Exercise also is an important thing here. The recommendation right now, at least, is for 150 minutes a week. That's 30 minutes, 5 days a week. I like to emphasize with patients that that should be something that makes you sweaty. So that may be setting the bar low in Florida, something that's getting their heart rate up, and not simply kind of strolling leisurely with their dog around the neighborhood. You're aiming here for a weight loss of 5 to 10% at 6 months. And so that goal should kind of help you set reasonable and realistic goals with patients. All the time people come in and say they want to lose 150 pounds. And we all know that that's not realistic, and you want to set goals where people can feel like they're actually achieving something rather than, failing at a goal that was unrealistic and unachievable to begin with. Additionally, if people smoke and if they drink alcohol, you want to talk about stopping both of those, as both affect people's cholesterol levels. And then if you do end up starting medications, you're going to regularly monitor a patient's lipid levels, both for response and for adherence to medication. So the American Diabetes Association also has specific recommendations about lifestyle modifications. They suggest, focusing specifically on weight loss, a very similar diet to what I spoke about earlier, a reduction of saturated fat and trans fat, and increasing fibers and plants, increasing physical activity should be recommended to improve lipid profiles in patients with diabetes. It also improves your blood sugar immensely. So it treats both things. And then, so for patients who have elevated triglyceride levels and low HDL, the best therapy we really can offer is exercise and also improving their diabetes management. Furthermore, for patients of all ages with diabetes and atherosclerosis, high intensity statin therapy should be added to lifestyle therapy. So they're basically reaffirming the recommendations from 2013 from the American Heart Association. For patients with diabetes who are younger than 40, who have other atherosclerotic disease risk factors, the patient and the provider should talk about using moderate intensity statins in addition to lifestyle therapy. Usually the AHA recommendations don't talk about statin therapy in people under the age of 40 unless you have an extremely high LDL. And so the ADA here is taking a slightly different approach, given that they're looking at patients who are at high risk to begin with, given their diabetes. For patients with diabetes who are 40 and over without atherosclerosis, they recommend using a moderate intensity statin, again, along with lifestyle therapy. And for patients with diabetes and atherosclerotic disease, if their LDL is greater than 70 and they're on a maximally tolerated statin dose, they suggest the consideration for additional lipid lowering therapies. So obviously a lot more to say about dyslipidemia, but I'm going to move on to talking briefly about smoking. Smoking is the leading preventable cause of disease, disability, and death in the United States. It results in more than 480,000 premature deaths each year in the US and accounts for approximately 20% of all deaths. Smoking increases the risk for all-cause mortality and has been found to increase risk for cancer, lung, liver, colorectal, respiratory diseases, and cardiovascular disease, diabetes. It impairs immune function and increases risk for autoimmune disease and eye disease, and also is related to erectile dysfunction in men. People with serious mental illness have high rates of smoking and therefore likely experience a disparate increased burden of disease and mortality mortality from smoking related cardiovascular disease, and then would also have high rates of all of the other conditions that I mentioned. This is from a large kind of survey study looking at factors affecting prevalence and risk of smoking. They found higher rates in men, in adults 25 to 44, people with a lower educational level and a lower income, patients identified as LGBT, and patients with what they just qualified as mental health conditions. So going off of that, up to an 80% prevalence in patients with schizophrenia and similar numbers in patients with bipolar disorder, which makes these patients with serious mental illness about 2 to 3 times more likely to smoke than people in the general population. So an overall approach to smoking cessation, I would guess most of you, if not all of you, are familiar with the 5 A's approach: to ask about smoking, advise patients to quit through a clear, personalized, direct message, assess whether a patient is willing to quit, provide support in assisting patients to quit, and then arrange for follow-up and support. So screening for smoking is easy. You just ask about it. The intervention is then encouraging and motivating patients to quit. And it's important to realize that this is a really long process, usually over multiple visits and years with multiple failed attempts most frequently. And it may involve pharmacotherapy like nicotine replacement or other medications as indicated, and most importantly, as desired by the patient. So the USPSTF recommends screening all patients, all adults for tobacco use, and then providing behavioral interventions and approved medications to assist patients in quitting. So in terms of assisting patients to quit, there is evidence to support both behavioral and pharmacotherapeutic interventions. In terms of behavioral intervention, that includes in-person behavioral support and counseling, telephone counseling, self-help materials alone or combined also with pharmacotherapy. There's evidence that supports both minimal behavioral intervention, such as one visit that's less than 20 minutes, and then also intensive interventions that are greater than 20 minutes over at least 2 visits. When a physician is advising a patient to quit, those effectively increase the proportion of adults who successfully quit and remain abstinent for at least 6 months. And even these very brief in-person behavioral counseling sessions that are less than 10 minutes effectively increase the proportion of adults who quit and remain abstinent for up to a year. So less interventions that are less than 3 minutes, so we went from 20 minutes to 10 minutes to 3 minutes, are less effective, but also more effective than not doing anything and not talking about cessation at all. In terms of pharmacotherapy, you have various options for nicotine replacement, for bupropion, and for varenicline, and those can all be added with behavioral counseling interventions or used on their own. For the sake of time, I'm not going to go into detail, as that could obviously be a lecture by itself. Once you've talked to a patient about what sort of interventions interest them, and made a plan for them, ask them about a quit date, had them set a quit date, make sure to follow up with them about that quit date. It's really hard for all of us to do that. We're all busy, have a lot of patients, but maybe make an appointment for that day or for the next day, have them come in, have a nurse call them if you have time, if you're able to do it, but try and make patients realize that we're looking at that date as part of treatment, and that we're approaching smoking like a chronic disease, just like we would approach their dyslipidemia or their diabetes. And that's particularly an effective approach in patients who are motivated to quit. And you should continue to follow up with them, continue to ask about it, even as they become abstinent for hopefully a longer and longer period of time. So another risk factor for cardiovascular disease is hypertension. About 30% of the adult US population has hypertension, and in 2010 it was implicated in the cause of death for about 350,000 Americans. It is the most commonly diagnosed condition at outpatient office visits. I would say very frequently patients who I'm seeing who haven't seen a doctor in 5-6 years or more, when they come in, they have high blood pressure, and that's kind of the first diagnosis that I make for them. It is a major contributing risk factor to heart failure, heart attack, stroke, and chronic kidney disease. So by effectively treating hypertension, we can hopefully prevent all of these much more disabling conditions. You see a very high prevalence again, and an increased relative risk in patients with both schizophrenia and bipolar disorder. The USPSTF recommends screening for high blood pressure in adults aged 18 or older. And they also, I believe this recommendation was in 2015 or 2016, recommend that you make your diagnosis of hypertension based off of blood pressure measurements from outside of the clinical setting. So that's not to say if somebody comes in with a blood pressure of 180 over 100 that you are going to send them home to do confirmatory testing. But for patients with those borderline numbers, 140, 150, have them check at Publix, have them, if they have a cuff at home, have them check at home and bring you back some readings, because it was found that the prevalence of white coat hypertension is so high that we were basically misdiagnosing people if we were basing our readings just off of in-office readings, particularly for those borderline patients. So in terms of the recommendations from the ADA, so these again are for patients with diabetes. They recommend measuring blood pressure at every clinical visit. Patients with the blood pressure over 140 over 90, which is the cutoff that they're using here as abnormal and as starting medication, should have their blood pressure confirmed using multiple readings over different days to make a definitive diagnosis. They also recommend home measuring of blood pressure, and they also say that you should always look at the clinical picture of your patient. So patients with higher risk of cardiovascular disease, with severe dyslipidemia, who smoke, who are obese, may benefit from a lower target such as 130 over 80, as long as you can push their blood pressure that low without undue treatment burden. So without dizziness, without symptomatic hypotension, and without polypharmacy that becomes really difficult for a lot of patients to manage. So in terms of treatment goals, this is an evolving topic right now. These guidelines are JNC 8. I also have a slide coming up about the AHA guidelines that came out at the end of last year. And we're still really trying to figure out how we want to apply both of those guideline sets. So JNC 8 did not address the diagnosis of hypertension in its 2014 guidelines, but they did talk about blood pressure goals and the blood pressure at which you would start medications. So the top boxes here, looking at a goal of less than 140 over 90, is for patients under the age of 60 and patients with diabetes or chronic kidney disease of any age. They allow, or JNC 8 allows, for patients over the age of 60 without diabetes or chronic kidney disease. They're looking just at a goal of 150 over 90. In terms of screening guidelines, JNC 7, which obviously came before JNC 8, recommends screening for high blood pressure at least once every 2 years in adults with blood pressure less than 120 over 80, and every year in adults with blood pressure of 120 to 139 systolic. Again, it's routine, at least in primary care offices, that anytime anybody comes in, we're screening their blood pressure and checking their blood pressure, both for screening for hypertension and also because it can be important information for us in patients who are sick. the 2017 American College of, it was the American College of Cardiology, not the American Heart Association. Their guidelines defined a normal BP as less than 120/80. And they recommended starting treatment at a blood pressure greater than 130/80 in patients with clinical cardiovascular disease and in patients with no clinical cardiovascular disease, but with a 10-year ASCVD risk of greater than 10%. And they then looked at the goal of greater than 140/90, or starting treatment at 140/90 for patients with no cardiovascular disease and a 10-year ASCVD risk less than 10%. And so I think a lot of the popular media that sent a lot of my patients into clinic asking me if they now had hypertension didn't necessarily focus on the ASCVD risk calculation, and really just said overall everybody should have a blood pressure less than 130/80. And these guidelines are still a little bit more complicated than that and a little bit more nuanced than that. They also still recommend that prior to labeling a patient with hypertension, it's important to use an average on greater than 2 readings over greater than 2 separate days to estimate the individual's level of blood pressure. And as part of that, out of office monitoring and self-monitoring of measurements are recommended to confirm the diagnosis. And so as you can kind of see, there's a pattern here of look at blood pressure readings outside of the office. And so I fully recognize that particularly for patients perhaps with severe, serious mental illness, or patients with multiple psychosocial stressors and who don't have a car and don't have money for food or are struggling just to eat, that checking blood pressure at home can be difficult. So obviously you need to consider both the levels in the office and your patient's reality about whether that's a reasonable expectation for them. In terms of treatment guidelines, JNC8 has this nice algorithm here. I didn't provide the entire thing so that hopefully you can actually read it, but generally they recommend that you start a thiazide diuretic, chlorthalidone or hydrochlorothiazide, an ACE, an ARB, or a calcium channel blocker as first-line medications. Except in a Black population, they recommend specifically the thiazide or the calcium channel blocker. So the ACE and the ARB is not recommended as first line in the general Black population. But in all patients with diabetes or chronic kidney disease, an ACE or an ARB remains the first line option for those patients for the renal protective effects of the medication. So there are a lot of medical conditions that can also kind of guide our treatment options for hypertensive management. And I think in a lot of these more nuanced cases like pregnancy or active CAD and CKD, you would probably be most definitely be referring to a primary doctor or a specialist. In terms of lifestyle management for hypertension, again, you can see a common theme here, focusing on weight loss for overweight or obese patients. This can include, again, talking about that heart-healthy diet, talking about the DASH diet and sodium restriction, and really emphasizing increased physical activity. You want to talk to patients about limiting their alcohol intake. So that's no more than 2 drinks a day in men and no more than 1 drink a day in women. And then also emphasize the control of other cardiovascular disease risk factors, such as smoking, diabetes, dyslipidemia, psychosocial stressors, and sleep apnea as well. So all of these risk factors are really interconnected. It's important to recognize here that the usual impact of each of these individual lifestyle changes is about 4 to 5 mmHg decrease in the systolic blood pressure, and even a little bit less than that in the diastolic blood pressure. And so if you have patients who are very hypertensive, with severely elevated systolic blood pressures, it makes a difference, but it's not going to really substitute the need for pharmacotherapy. if a patient is effectively eating a diet that's low in sodium, saturated fat, and total fat, and high in fruits, vegetables, and grains, that very I think that's a very difficult diet to maintain. But if people are effectively maintaining it, you may see a larger decrease in the systolic blood pressure of up to 10 or 11 mmHgs. So that's a significant decrease, particularly if coupled with a low dose of a medication. So moving from hypertension to diabetes, approximately 86 million American adults have impaired glucose tolerance. So important to realize, impaired glucose tolerance is not the same thing as diabetes. This is what we call more a pre-diabetes. And I explain that to patients as something that puts them at risk for diabetes in the future. It shows me that their sugar is a little high, but not high enough to have diabetes. And for some patients, that's a huge motivating diagnosis to get, a huge motivating conversation, because they're scared and they want to prevent themselves from developing diabetes in the future. Of this cohort of patients with impaired glucose tolerance, somewhere between 15 to 30% of them will develop type 2 diabetes within 5 years if they do not implement lifestyle changes to improve their health. We also are now, particularly for people at the kind of the higher end, the more borderline diabetic end of this, we're treating people with metformin to help delay the progression to diabetes. Again, in schizophrenia and bipolar disorder, you're seeing an undue burden of disease and an increased relative risk, not quite to the extent of the other risk factors that we talked about earlier, however. And a lot of this is secondary to medication side effects, which I'm sure you are all very familiar with, and also poor dietary choices, poor access to healthier foods, and difficulty emphasizing that fruit and vegetable diet. In terms of screening for diabetes, the USPSTF recommends screening for abnormal blood glucose or diabetes or prediabetes as part of a cardiovascular disease risk assessment in adults aged 40 to 70 who are overweight or obese. And then for patients with abnormal blood glucose, they should be referred to intensive behavioral counseling interventions to promote all of those lifestyle changes that we talked about. They also have recommendations that for people who have a family history of diabetes, have a history of gestational diabetes or polycystic ovarian syndrome, or are members of certain racial and ethnic groups, including African Americans, American Indians, Asian Americans, Hispanic, Latinos, Native Hawaiians, or Pacific Islanders. So that's basically everyone, or close to everyone, may be at increased risk for diabetes at a younger age or at a lower body mass index. So, and that those patients may benefit from being screened earlier than that age of 40. And in practice, we end up screening most people by the time they're in their late 20s and much earlier if they are obese or have a strong family history. So, again, we understand and know guidelines and we apply them differently in the clinical setting. So in terms of a diagnosis for diabetes, there are three kind of main tests here. We are relying almost entirely now on the hemoglobin A1C. A normal hemoglobin A1C is less than 5.7. Impaired glucose tolerance is a hemoglobin A1C of 5.7 to 6.4, and greater than 6.5 is diabetes. Looking at fasting glucose, 100 to 125 is impaired glucose tolerance, or so less than 100 is normal. And then diabetes is considered a fasting glucose of 126 or greater. Again, not generally using the fasting glucose to make a diagnosis of diabetes. There's also a 2-hour glucose tolerance test. The patient's given a 75-gram glucose load, and their blood sugar is measured after 2 hours. This is not a test that I see a lot done in practice. Nobody likes drinking that sugar load, and it takes 2 hours of someone's time, which is pretty crazy. And a lot of our patients don't have that kind of time. A lot of us don't have that kind of time. And so these are the cutoffs for the glucose tolerance test. If everything is normal, the screening interval is a little unclear, probably every 3 years for patients with normal results. But like I mentioned, in terms of screening for hyperlipidemia in practice, it's a test that we do every year for normal results, and every 3 months for people with diabetes, and somewhere between every 6 months and every year for people with pre-diabetes, depending on the extent of their disease. So in terms of treatment goals, so if someone is diagnosed with diabetes, what do we want their hemoglobin A1C to be? The ADA recommends a goal for many non-pregnant adults being 7. Of interest, earlier this month, a few weeks ago, the American College of Physicians changed their recommendation to say that most patients with type 2 diabetes should aim for a hemoglobin A1C between 7 and 8, so of less than 8. And so this represented a loosening of their 2007 recommendation, which was in line with the ADA recommending a goal of less than 7. They kind of cited evidence that treating to targets of 7 or lower rather than 8 does not necessarily reduce the risk for death or for microvascular events over a 5 to 10 year period, but did result in substantial harm such as hypoglycemia. And so in practice, the treatment goal ends up being really tailored to the patient and the management ability of the patient. But generally, we're aiming for somewhere between 7 and 8. There are some patients where a goal of 6.5 may be reasonable if that can be achieved without significant hypoglycemia or polypharmacy. Those that you may be looking at a goal of 6.5 are patients with a short duration of diabetes, type 2 diabetes, with lifestyle or metformin only, so drugs that have a very low risk of hypoglycemia to begin with, patients with a long life expectancy, and patients with no significant cardiovascular disease. And they also, or the ADA also recognizes that less stringent A1C goals, such as 8, may be appropriate for patients with a history of severe hypoglycemia, those with limited life expectancy, advanced complications already from disease, extensive comorbid conditions, or longstanding diabetes, in whom it's really difficult to achieve this goal despite kind of full throttle and all-encompassing diabetes self-management, education, treatment, and monitoring. And so they're a little bit more pointed in patients who they say would be appropriate for that higher goal. Treatment in terms of pharmacotherapy is definitely beyond the scope of this lecture, but questions that I commonly get is that at an A1C of greater than 9, we're starting to think maybe about just starting patients immediately on insulin. I still tend to try oral medications because insulin is a life-changing medication strategy and requires the finger sticks and a lot of paraphernalia, injections, and I always want to make sure that someone really, really needs it before I put them on insulin. But from this kind of algorithm guideline from the ADA, you're looking at insulin for patients with an A1C greater than 9 who have symptoms. Between 7.5 and 9, you're probably going to start immediately on dual oral hypoglycemic therapy, and less than 7.5, you'll go right to a monotherapy. Metformin is a good tried and true affordable medication. In terms of preventative health, there are a lot of preventative health recommendations for patients. It can be very challenging to get all of this done every year. Recommend the annual eye exam and foot exam. one-time Hep B screening and vaccination if it's indicated, an annual urine microalbumin, screening for dyslipidemia like we've talked about, consideration for a statin, aspirin, and ACE inhibitor. You can consider the ACE inhibitor regardless of a patient's blood pressure for renal protection and to hopefully prevent microalbuminuria in the future. You want to give the pneumovax, the 23-valent, not the 13-valent vaccine. Even if the patient is under the age of 65, you would give that once, and the flu vaccine in flu season. Generally, we follow up patients every 3 months until they're well controlled. If it's a new diagnosis, you may see the patient more frequently so that you can titrate their meds quickly. And once they are well controlled for a period of 6 or 9 months, you can hopefully space their visits out to every 6 months, particularly if they're only on oral medications. So going on to a closely connected disease, obesity, again, has a prevalence of about 30% of the population in the United States. It is associated with increased risk of diabetes, hypertension, cancer, ischemic heart disease, and early death. In terms of being overweight, which I will show you a graphic, is a BMI between 25 and 29.9. 40% of men and 28% of women in the United States are overweight. And about 5% of adults have a BMI over 40, which is class 3 obesity, morbid obesity, or an extreme obesity category. So that's like 5 in 100 or 1 in 20 adults. So obesity is also highly prevalent in people with serious mental illness, about 50% prevalence for both patients with schizophrenia and bipolar disorder. And that's about 1 to 2 times the relative risk compared to the general population. Just like with everything in medicine and in this presentation, it's a multifactorial kind of reason or explanation for this, including the medications that many of these patients are on, adherence to diet and kind of lifestyle modifications and preventative health, and then as well as their actual diet and what they're eating. So in terms of defining obesity, we look at the BMI, which is an indicator of the percentage body fat using a person's weight and height. So a normal weight or a normal BMI is considered 18.5 to 24.9. Overweight, you're at 25 to 29.9. And then obesity of varying classes and severities is at a BMI of 30 or over. And that's when we really start to see most of the severe complications of obesity that I mentioned briefly. The BMI may overestimate body fat in athletes and others with a muscular build, and it may underestimate body fat in older patients and others who have lost muscle mass. So within that population, I particularly see this kind of with young athletic men who have who are clearly very fit and of an appropriate weight, but end up being classified as overweight because of their muscular build. So something to again, keep in mind. You want to apply all of this to your knowledge of your patient. Waist circumference is also something that we talk about in terms of our evaluation of obesity. It may provide a viable alternative to BMI calculations. And in men, we're seeing increased risk of cardiovascular disease and diabetes with a waist circumference greater than 40 for men and greater than 35 for women. And so this alone may be an independent risk factor for cardiovascular disease. Again, when I gave this presentation with to a cohort of psychiatrists, they were all struggling to kind of see testing waist circumference in their offices. I don't know what you do in your office, and this may be something more for a primary care office. We do test waist circumference annually at the office where I practice. In terms of screening for obesity, the USPSTF recommends using BMI to screen all adults for obesity, and then the clinicians should refer patients with the BMI of 30 or higher, which classifies them as obese, to multi-component behavioral interventions. They are also currently working on an updated guideline for this, which will focus more on weight loss to prevent obesity-related morbidity and mortality, and look both at behavioral and pharmacotherapeutic intervention. And additionally, the screening interval for obesity is not well defined by the USPSTF guideline. In terms of management, so intensive multi-component behavioral interventions as recommended by the USPSTF are very extensive. They looked at programs that included 12 to 26 sessions in a year. Some of them were group sessions, some of them were individual sessions, some of them were actual physical activity, aerobics classes, going out and getting active together. They addressed setting weight loss goals, improving diet or nutrition, addressing barriers, self-monitoring, and ways to maintain lifestyle changes. And so that obviously is something that's challenging to implement in the real world outside of a study setting. I was at a conference recently where a group of researchers had looked at just giving scales to patients and looked at weight loss and maintenance, at least maintenance of weight versus weight loss versus weight gain. And they found that patients with a scale at home who were incentivized to step on it every day did better and managed to lose a significantly larger amount of weight than patients who are just in the normal intervention group. And to me, that seems like perhaps a more kind of realistic place to start for many of us and for many of our patients. You know, in terms of this sort of intensive intervention that led to an average weight loss of between 8.8 and 15.4 pounds. Along with that, you saw improved glucose tolerance and other risk factors for cardiovascular disease. There also is the recommendation, as I'm sure most of you are aware, to consider metformin for psychotropic medication-induced weight gain, although that is not currently FDA approved. Again, going to the American Diabetes Association recommendations, they talk about diet, physical activity, behavioral therapy for greater than 5% weight loss for patients who are overweight and obese with type 2 diabetes, and also recognizing that in order to make those recommendations, patients need to be in that contemplative stage of change, really looking to make those changes. And these interventions should be high intensity, have these kind of discrete sessions, focus on diet, physical activity, and behavioral strategies to achieve the caloric deficit that's needed to effectively lose weight. You may also consider for patients in the varying degrees of obesity categories, you may consider bariatric surgery or bariatric surgery referrals. And in order to qualify for bariatric surgery, patients must show evidence of being able to adhere to a post-operative treatment plan. Usually insurance companies also require a letter that states all of the other many things that patients have tried and failed to lose weight with. And because of the requirement to be able to adhere to a post-operative treatment plan, patients with serious mental illness are often excluded from consideration for bariatric procedures. These procedures are relatively effective. They have a high rate of side effects of vomiting and diarrhea, but you're looking at weight loss of up to 50% maintained at 10 years, remission of type 2 diabetes in 60 to 80% of patients by 2 years after surgery. And so those are huge changes for patients and huge improvement for patients. So in terms of talking to people about losing weight, I mentioned before the importance of setting realistic goals. You want to aim for a loss of 5 to 10% of starting weight. That's considered clinically significant. It decreases blood sugar, blood pressure, triglycerides, it will increase HDL. And so START was setting a goal that's less than 5% probably, but to tell patients that, you know, they don't need to lose half their body weight for it to improve their health and their disease outcomes. And so I find my biggest challenge in talking about obesity with patients is setting realistic goals and encouraging patients to set goals that are attainable. In terms, so really, we went through a lot today. People with serious mental illness are at increased risk of multiple chronic diseases and present unique challenges for high quality, effective treatment. Many of those challenges are related to the social determinants of health of patients with serious mental illness, access to care, their ability to comply with a treatment program, and also the physician barriers where physicians may be focusing more on mental health than on physical health needs. It is important to have an integrated approach to addressing modifiable risk factors for cardiovascular disease. The modifiable risk factors are the ones that I talked about today. You can't change your family history, obviously. So these are, you know, the 5 that we usually focus on because we can improve outcomes based on motivating people not to smoke and to lose weight, to take their medications. And then furthermore, something that I happen to be particularly interested in and think is particularly important is this move toward multifactorial risk stratification rather than creating absolute disease targets and goals. And we've seen that risk stratification integrated more and more into treatment plans and treatment goals over the last number of years. And so that is my crash course, my very quick talk covering a lot of information. I hope you guys learned something. I think there are a few minutes for questions. So I think that, and myself included, most primary care doctors prefer to focus on the kind of creating change that is sustainable. And so change, meaning changes in diet and physical activity that have more effect than just losing weight. And that with many medications, you see many of the weight loss medications like phentermine, you see side effects, and you see people who may be effective at losing weight for a short period of time, but when they stop the medication, the weight comes back because they haven't been motivated or haven't been able to make the changes that would result in kind of more long-term weight loss. And so that's not something that I have patients ask all the time for medication for weight loss. And I have basically that same conversation with them that I want them to be able to make changes that will last in not only losing weight, but in creating an overall healthier person and healthier body. And I don't think you see that so much when somebody's taking just a pill. I definitely think there are always places for bariatric surgery and other methods, but it's not a route that I really have chosen to go that much. And I'll be interested to see what the USPSTF says about the role of pharmacotherapy in obesity management later this year, I think.